Now, the mechanism of concentrated urine formation, we will be looking into the physiological mechanism responsible for concentrated urine formation across the renal tubules, the role of medullary osmotic gradient in that, role of countercurrent exchange and multiplier mechanisms, as well as the role of urea recycling and the related abnormalities to the diluted and concentrated urine formation. So, starting from the basic concept, as we have discussed the dilute urine formation, now is the concentrated urine formation, and here where comes the role of the juxtamedullary nephrons. As we discussed while discussing the physiological anatomy of the kidney, 20 to 30% nephrons are juxtamedullary nephrons, where the glomerulus is present almost at the corticomedullary junction, and their loop of Henle are so long that they dip down even to the tip of the renal pyramids. And instead of the peritubular capillaries, these are specialized to form the Vasa recta over here along with these juxtamedullary nephrons. These nephrons are particularly involved in the formation of concentrated urine formation. Concentrated urine formation, the maximum osmolarity may achieve maybe 1200 to 1400 milliosmoles per liter, although the other animals may adapt differently. For example, those living in the deserts may concentrate the urine up to 10,000 milliosmoles per liter, and some freshwater animals only can concentrate up to 500 milliosmoles per liter. The obligatory urine volume concept is the minimum volume of the urine that must be excreted each day to remove the body's daily solute load, including the metabolic waste and electrolytes, and this is dependent upon the kidney's maximum concentrating ability. For example, a person is very much dehydrated, but still the person needs to excrete the metabolic waste products by producing a minimum volume of urine so that the maximum water can be retained by excreting the maximum salt load, waste load. So this is called as obligatory urine volume, and this is dependent upon the kidney's concentrating ability. How can we calculate this? Let's look into it with this example. Normal average solute load in adult humans is 600 milliosmoles per day, including the waste products as well as electrolytes, and the average healthy kidney has a concentrating ability of 1200 milliosmoles per liter. So the obligatory urine volume comes out to be the solute load divided by the urine concentrating ability, that is 500 ml of urine must be produced every day despite the conditions to excrete this solute load. Here comes a related concept. Why drinking seawater causes dehydration? You are intaking water, yes, it is hyperosmolar, but still you are intaking water. So how does this lead to dehydration? And this can be explained by the concept of the obligatory urine volume, and you can look into it and get back. So the concentrated urine formation mechanisms, the basic requirement include the presence of antidiuretic hormone. Number 2, presence of a hyperosmotic medullary interstitium. This vasopressin is coming from the posterior pituitary. We'll look into the details in a while. This hyperosmotic medullary interstitium is developed by 2 mechanisms, including countercurrent, multiplier, and urea recycling. Once developed, it is maintained by another mechanism, countercurrent exchange mechanism. So we are going to look into the details of these 3 mechanisms as well during the session. This is showing the corticopapillary gradient. As you can see, the osmolarity from cortex to medulla is sequentially increasing, maximum at the renal papilla. So this is known as corticopapillary gradient, and you can appreciate the medullary interstitial hyperosmolarity, which is the basic requirement for the concentrated urine formation. A kidney can produce a concentrated urine only up to the osmolarity of the medullary interstitium. If this is only 1000 over here, the maximum achievable urine concentration will be 1000. If this is 800, maximum achievable urine concentration will be 800. So this is why this is the basic requirement to make the medullary interstitium hyperosmolar to achieve the maximum urine concentrating ability. So starting from what makes the medulla hyperosmotic, And the development is by two methods, including the countercurrent multiplier and the urea recycling. So first we will look into the countercurrent multiplier mechanism. Countercurrent multiplier mechanism occurs at the level of the loop of Henle, and this is brought upon by the tubular characteristics of ascending and descending limbs of the loop of Henle. Let's quickly revise the characteristics of the thin descending and ascending loop of Henle, particularly for the purpose of understanding the countercurrent multiplier mechanism. As we discussed in the previous session, the thin descending limb, this is thin descending limb. This thin descending limb is much more permeable to water and less permeable to salts, whereas the thin ascending limb is virtually impermeable to water. So keep in mind these two characteristics to understand the mechanism of countercurrent multiplier. Also, if we look into the thick ascending limb, it has a high active reabsorption capacity of salts, but minimal ability to reabsorb the water. So let's get back to the countercurrent multiplier mechanism. We will look into the mechanism step by step. So on the first hand, you can see this is the descending loop of Henle. This is the thin and thick ascending loop of Henle. As the filtrate enters into it, this is iso-osmotic, which was filtered and reabsorbed across the proximal convoluted tubules. Still, it is having the osmolarity of 300, which is close to that of the plasma. Now, if we look at the step 2, this is showing the active reabsorption of the salts from the thick ascending limb of the loop of the Henle, which is highly permeable to the sodium chloride and can reabsorb it by the active transport mechanism. If you memorize sodium potassium 2 chloride mechanism. Now, as this is reabsorbing salts across this tubular segment, you can see the osmolarity inside the tubule has decreased from 3 to 200. And the osmolarity in the interstitium has increased from 3 to 400 because of the addition of this salt float. So active ionic pumping creates a gradient of 200 milliosmoles per liter between the tubular fluid and the interstitium. Next, you see when the fluid is descending down from the proximal convoluted tubule through the descending limb of the loop of Henle. Here this is showing the reabsorption of water. As you know, the descending limb is more permeable to water as compared to salts. The water keeps on being reabsorbed. What is left behind are the salts. So this is increasing the osmolarity across the descending limb of the loop of Henle. As much decrease, as much is present in the interstitium until osmotic equilibrium is achieved. So osmosis of water from the descending limb of the loop of Henle to reach the osmotic equilibrium. At point 4, you can see the filtrate or tubular fluid that entered the ascending limb of the loop of Henle is now having an osmolarity of 400 milliosmoles per liter. Here again, what would happen? It will again cause the active reabsorption of the salts. The salts will enter into the interstitium, further increasing the osmolarity of the interstitium from 300 to 500 and decreasing the osmolarity in the tubular fluid, this time even further 150 milliosmoles per liter. So additional reabsorption of salts, additional increase in osmolarity of the interstitium and decrease in the osmolarity of the tubular fluid. This is what is occurring step by step in the kidney to increase the renal interstitial osmolarity, and this keeps on happening again and again until the osmolarity of 1200 milliosmoles is achieved in the renal interstitium close to the tip of the renal pyramids. And this is all occurring on the same basic concept that ascending limb is capable of actively transporting sodium chloride but impermeable to water, whereas descending limb is capable of reabsorbing water and less permeable to salts. So the osmotic equilibrium ultimately is achieved in the descending limb of the loop of Henle, while the ascending limb is helping in creating a higher osmolarity in the medullary interstitium. Together, this process is known as countercurrent multiplier mechanism. It is called countercurrent because the movement of fluid is opposite in both the limbs, one descending down, other ascending up, one absorbing salt, other absorbing water, and multiplier because it is multiplying the osmolarity in the renal interstitium. One other thing you can appreciate over here that throughout the steps at each point when the active transport of salts occur, a gradient of approximately 200 milliosmoles is produced every time from 200 to 400, and then you can see over here from 150 to 350, and in the next image you can see 300 to 500 and 5 to 7, 8 to 1000, 1000 to 1200. So this is the capacity of this active transporter, that it can achieve maximum this much concentration gradient of 200 milliosmoles per liter between the tubular fluid and the medullary interstitium. To quickly sum up the countercurrent multiplier mechanism, this is occurring at the level of the loop of Henle because of the tubular characteristics. The descending limb is more permeable to water. The ascending limb is impermeable to water but has a huge capacity to actively transport sodium chloride, because of which hyperosmotic medullary gradient can be maintained and in fact achieved. And this is not occurring in the kidneys every day. This osmotic equilibrium is developed by the countercurrent multiplier mechanism and then maintained on day-to-day basis by another mechanism called countercurrent exchange mechanism. This countercurrent multiplier mechanism will only work to re-establish the osmotic gradient if this is dissipated by some reason. For example, by a disease, by a drug. If it gets dissipated, only then it will come into action again and produce the osmotic gradient again. Otherwise, this is the duty of the countercurrent exchange mechanism to maintain the osmotic gradient, which is on the first hand established by the countercurrent multiplier mechanism. So once the osmotic medullary interstitium hyperosmolarity is achieved, when the tubular fluid at 100 milliosmoles per liter from the early distal convoluted tubule will descend down in the cortical and medullary collecting tubule, what will happen? This 100 milliosmoles per liter we have discussed in the previous session on dilute urine formation. Now let's see. If this fluid descends down and ADH is absent, water will not be reabsorbed and will be left behind. A dilute urine will be formed. But if ADH is present, large amount of water will be reabsorbed from tubule into the cortex interstitium. Similarly, in the presence of ADH, the medullary collecting ducts will become permeable, increasing the water reabsorption and making the tubular fluid more concentrated. And in this image, you can appreciate this. The 100 milliosmoles per liter tubular fluid entered. The water kept on being reabsorbed, increasing the osmolarity in the tubular fluid up to the level of the medullary interstitium. So this is the maximum achievable concentration of the urine. Now the role of urea recycling in achieving a hyperosmotic medullary interstitium. This is also playing the role in establishing the hyperosmotic medullary interstitium, and we can explain this by using the image we just have in front of us. As you can see over here, the different tubular segments starting from the filtration of the urea. When it is filtered, we take this level as the 100%. We take it as the baseline. When it passes through the proximal convoluted tubule, the reabsorption of urea occurs as shown in this image, and when it goes out of the proximal convoluted tubule to the descending loop of Henle, only 50% of the urea is remaining and 50% was reabsorbed over here. Now this 50% of the remaining urea content while passing through the descending and ascending loop of Henle is modified. How is it modified? That further urea is added to this, as you can appreciate over here by this urea transporter A2. When this reaches the thick ascending limb of loop of Henle, this is again 100%. So 100% when filtered, 50% reabsorbed, at the PCT, but re-added in the thin descending and thin ascending limb of loop of Henle. So at thick ascending limb of loop of Henle, this is again 100%. Throughout this segment, thick ascending limb, early distal tubule, cortical collecting tubule, this segment is impermeable to the urea, as is shown by this solid border line over here. These segments are not permeable to urea, and the 100% remaining will remain 100% till over here. When it reaches the medullary collecting duct, again this segment is permeable to urea in the presence of the ADH. ADH inserts urea transporter A1 and A3 at this tubular segment, which can reabsorb urea again. As you can see, the urea is being reabsorbed. Depending upon the presence or absence of the ADH, the variable amount of urea is reabsorbed. Mostly this is 80% reabsorbed and only 20% remaining in the urine. Now, what is different and unique about this urea recycling is mostly the substance being reabsorbed from a tubular segment gets into the peritubular capillaries and taken away. But here, this stays in the interstitium, and from the interstitium, instead of entering the blood vessel, it re-enters another tubular segment. That is why it is known as recycling. It is coming from the medullary collecting duct, entering the interstitium and re-entering the thin ascending and descending limb of the loop of Henle. So this urea recycling is occurring again and again, the same urea circulating between two tubular segments while passing through the interstitium. And what gain we have from this? A higher medullary interstitium osmolarity. So this is how urea recycling plays its role in keeping the medulla of kidney osmotic. As this is impermeable in the cortical segments, this is not contribute to the cortical hyperosmolarity, which is not existing actually. So the contribution of urea to osmolarity, the 40 to 50% of the medullary osmolarity is contributed by the urea recycling. Some segments are, however, impermeable to urea. Antidiuretic hormone inserts urea transporter A1 and A3 on the inner medullary collecting duct, and thin loop of Henle is facilitated by urea transporter A2. Physiological significance: increased urea reabsorption or decreased urea excretion will occur if a concentrated urine is being formed and the ADH level is high. As we know, this is going to insert urea transporter A1 and A3 for the reabsorption from the inner medullary collecting duct. And there are few other conditions which increase the urea reabsorption, including high protein diet, a low GFR, high plasma concentration of urea. All these are going to increase urea reabsorption, whereas less urea reabsorption and more excretion can occur when the dilute urine is being formed and ADH is low. If there is fluid excess, high urine flow rate. So that's all about the urea recycling and its physiological determinants. Next comes the countercurrent exchange mechanism, which comes into play to maintain the hyperosmotic medullary interstitium. Once it is developed by the urea recycling and countercurrent multiplier, countercurrent exchange mechanism will be keeping it intact. And this is occurring at the level of the Vasa recta, which are the specialized peritubular capillaries of the loop of Henle of the juxtamedullary nephrons. The two most important characteristics of Vasa recta which help them maintain this countercurrent exchange mechanism include a very slow, sluggish blood flow. The Vasa recta is receiving only less than 5% of the total renal blood flow. Number two, its arrangement in the descending and ascending limb in hair loop pattern. Opposite flow in the descending and ascending limb helps in maintaining the renal medullary interstitium osmolarity. We will look into it in a while. the details. The medullary blood flow is slow and sluggish, accounting for less than 5% of the total renal blood flow, which is sufficient to supply the metabolic needs but minimize the solute loss from the medullary interstitium. Also, it acts as a countercurrent exchanger, minimizing the washout of solutes from the medullary interstitium. Let's see how. The histological characteristics of the descending limb of the vasa recta. It has non-fenestrated endothelium and facilitated transporters for the urea. It can uptake the solutes, whereas the ascending limb of the vasa recta is having fenestrated endothelium, which is consistent with its function in conserving solutes, that it loses the solutes back to the interstitium while ascending up. The descending limb, as you can see in this image, is picking up the solutes while it is descending down from the cortex to medulla, and it is losing water into the interstitium. What happens by the end? It reaches the tip of the renal pyramid. The osmolarity inside reaches up to the 1200 milliosmoles per liter at the tip. Next, when it ascends up, the ascending limb has the opposite characteristics. It can lose solutes back into the interstitium as the endothelium is fenestrated, and it can uptake water. As you can see in this image, it is re-entering the vasa recta. So ultimately what happens? The plasma in this vasa recta entered at 300 milliosmoles per liter, increased osmolarity to 1200 while descending down. While ascending up, the osmolarity was back to the approximately 300 milliosmoles per liter. So it did not take away any excessive solutes. What it took in while descending, it gave back while ascending, thus maintaining the osmolarity in the renal medullary interstitium. Although large amounts of salt and water were exchanged, but there were little net washout because of the U-shaped loop, and high medullary interstitium osmolarity was preserved. Can you just imagine if this vasa recta was in this shape rather than a U-shaped turn? From here, the peritubular capillary blood entered at the arterial end, 300 milliosmoles, descended down to 1200 milliosmoles per liter, and here it entered the venular end. All the osmolarity, 1200 milliosmoles per liter, would have entered into the venous blood, and the medullary osmolarity would have been washed away. But the nature has kept it as a U-shaped turn. The same capillary blood ascends up throughout the medulla to reach the osmolarity 300 again before it drains into the venous end. Increased medullary blood flow, if occurs in cases like taking some vasodilators, increased arterial pressure, the blood flow in the vasa recta can be so accelerated and speed might be increased too much that it may not have adequate time to re-enter the salts back to the interstitium, and in such cases the medullary hyperosmolarity can be lost. The effect would be washout of solutes, decreased osmolarity, so the maximum urine concentrated ability would be lost. Now that we have seen the countercurrent, multiplier and exchange mechanisms, I hope you can tabulate a few differences between the two. To highlight a few, the countercurrent multiplier main site of action loop of Henle, exchanger vasa recta. Primary function of countercurrent multiplier mechanism is establishment of the hypermedullary osmolarity, while exchange mechanism is preserving it. The mechanism, the characteristics of tubular segments, and here the characteristics of ascending and descending, blood vessel characteristics. This is the image showing what would have happened if this was not in a U-shaped turn, and all the osmolarity would have been washed away into the venous end. This image is showing the sum up of the mechanism of concentrated urine formation, that when an isoosmotic fluid enters the Bowman's capsule, while passing through the proximal tubules, both salts and water are absorbed equally, making it isotonic by the end of the proximal tubule again. While going through the loop of Henle, the osmolarity of the fluid first increases up to 1200 milliosmoles per liter. Then from the ascending limb of the loop of Henle and thick ascending limb of the loop of Henle, the osmolarity again decreases, and minimum osmolarity is achieved in the distal tubule, where 100 milliosmoles per liter may be achieved. Then while passing through the collecting tubule, the response can be different. If ADH is absent, the osmolarity may further decrease up to 50 milliosmoles per liter, producing large volume of dilute urine up to 20 ml, you can see over here. And in the presence of the ADH, the osmolarity may increase up to again 1200 milliosmolars, and small volume of concentrated urine may be produced. And this is the summary of what we have discussed by now while discussing the dilute and concentrated urine formation for your review. I hope you can self-assess yourself. In the presence of vasopressin, in the absence of vasopressin, greatest fraction of filtered water is reabsorbed. Of course, the answer remains the same. 65% of water is going to be reabsorbed from the PCT, either in the absence or in the presence of ADH. Now, the osmolar clearance. This is a related concept. Osmolar clearance is volume of plasma cleared of all solutes per minute. If you know the concept of clearance, you know clearance is equal to concentration of the substance in the urine divided by into urine flow rate divided by concentration of the substance in the plasma. So same formula applies to the osmolar clearance as well. Urine osmolarity multiplied by urine flow rate divided by the plasma osmolarity. If a person is having, okay, let's first see the free water clearance and we will see the clinical application then. The rate at which free water is excreted. First, we have seen the osmolar clearance, how much osmoles are being cleared, then how much water is being cleared. Rate at which free water is excreted can be calculated by subtracting the osmolar clearance from the urine flow rate. If a person is having excess fluid in the body and wants to get rid of extra fluid, the free water clearance would be positive. There would be more urinary flow rate and less osmoles cleared. While a person who is dehydrated and want to retain water will have a negative water clearance, as the urine flow rate would be less and osmoles cleared would be more. So we call it positive or negative free water clearance, and you can relate it to this formula as well. And finally, the disorders of urine concentrating ability, as you must be knowing, the diabetes insipidus. This is signified by the excessive dilute urine formation despite the person is dehydrated or at risk of dehydration, and the primary pathology is either the absence of the ADH, like in the central diabetes insipidus, or the absence of the ADH receptors or malfunctioning of the receptors in the nephrogenic diabetes insipidus. Clinical features in diabetes insipidus will include polyuria, of course, dilute urine, large volumes. When there is loss of excessive fluid, the person may be having high plasma osmolarity, causing excessive thirst, calling polydipsia. Risk of hypernatremia if adequate replenishing of water is not done, and this is more of a risk in those people who are hospitalized or unconscious, or small children who cannot uptake as much water as required. Diagnostic approach First of all, measure the plasma and urine osmolarity. A patient of diabetes insipidus will be having a very low urine osmolarity despite a high plasma osmolarity. To confirm it, you can do the water deprivation test. In response to water deprivation, ideally antidiuretic hormone would be released and the urine osmolarity should be raised. But in a patient of diabetes insipidus, despite the water deprivation, urine osmolarity will remain the same, not increased. On the third step, you can undergo Desmopressin challenge test to differentiate between the central and nephrogenic diabetes insipidus causes. Desmopressin is a vasopressin synthetic analog. If given, it increases the urine osmolarity in patients of central diabetes insipidus who are lacking the ADH, but the urine osmolarity does not change in those people in which the problem is at the receptor level, that is nephrogenic diabetes insipidus. Treatment of central diabetes insipidus includes giving the desmopressin, the vasopressin analog, as therapeutic treatment. For nephrogenic diabetes insipidus, the primary cause should be found out and cured if possible. And symptomatic treatment may include low salt diet, fluid replenishment, as well as thiazide diuretics. Though it may seem contradictory, a patient is already having polyuria and we are giving diuretics. But if you think logically, the use of this thiazide diuretics is going to help in excretion of the salts as well and improve the osmolarity of the urine being produced and decrease the risk of hypernatremia being developed in such patients. Nephrogenic diabetes insipidus has multiple causes. Some genetic causes includes mutation in the receptors of the ADH. Some autosomal causes include the mutations in the aquaporins channels, and the clinical outcome in all of them is going to be polyuria, polydipsia, dehydration with normal or a high ADH level but no response to water deprivation or desmopressin. And this is going to help you out in comparing the normal response to water deprivation test and desmopressin challenge among patients of central and nephrogenic diabetes insipidus. This is a quick comparison of central and nephrogenic diabetes insipidus, and we have discussed it. Cause here, this is absence of ADH, and here this is the inability to respond to ADH. ADH levels will be low or absent in central diabetes insipidus, normal to high in nephrogenic. Urine output will be large volume of dilute urine in both. Response to desmopressin will be seen in central diabetes insipidus but not in nephrogenic diabetes insipidus. Complications, severe dehydration and hyponatremia in both. Treatment also varies depending upon it if it is because of absence of ADH or non-response to ADH. This is a clinical scenario. Please have a keen look. This person is suffering from high volume of urine, excessive thirst, both polyuria and polydipsia, diagnosed with bipolar affective disorder and is taking lithium for the past 1 year. If we look into the lab reports, serum sodium is relatively high, plasma osmolarity is high, urine output is low and urine osmolarity is low despite the patient being dehydrated, and urine sodium level is also low. As we have seen, high volume of dilute urine. So most likely this patient is suffering from diabetes insipidus. And if we further look into the history details, the patient is taking lithium, which is responsible for causing non-responsiveness to the ADH at the receptor level. So this patient is suffering from nephrogenic diabetes insipidus. In comparison, if we look into the history of this patient who is having chemotherapy for lung cancer, is now presented as drowsy, dehydrated, urine and serum analysis showed a hypoosmolarity of the plasma urine output is low, urine osmolarity and urine sodium is high. So this patient is producing low volume, concentrated urine and retaining more water than salts, resulting in decreased plasma osmolarity. So if we again think about abnormalities of ADH, this is excessively retaining water, producing concentrated urine. So this patient is suffering from syndrome of inappropriate antidiuretic hormone secretion. This excessive vasopressin secretion leads to water retention and hyponatremia. There can be multiple causes, maybe some CNS disorder or pulmonary diseases. For example, in the scenario we have just seen, this is ectopic ADH production from lung neoplasm, ectopic vasopressin secretion, loss of inhibitory vagal input to the hypothalamus. So there can be multiple reasons leading to excessive ADH production, which we look into the one umbrella of syndrome of inappropriate antidiuretic hormone secretion. Effects in all of them is going to be dilutional hyponatremia, low plasma osmolarity, and of course in response to that, reduced aldosterone as well. Vasopressin escape mechanism is an important aspect. Despite having chronically high ADH, the patient may not present with edema, because when the ADH is high for prolonged time, the aquaporin receptors may be downregulated in the collecting duct. That will ultimately result in increased urine flow and limit hyponatremia. So this is the normal physiological response to a chronically raised ADH level, and we call it vasopressin escape mechanism. To treat it, antagonists of vasopressin receptors are given, like demeclocycline, and fluid should be restricted. And this is what we have discussed about these scenarios: the diagnosis, pathophysiology, diagnostic, and the treatment options. If we look into the difference between these two diseases, both are because of abnormalities of ADH. In one, this is high, in other, ADH is absent. ECF volume will of course be more in patient of SIADH. Plasma osmolarity will be high in diabetes insipidus patients. Serum sodium would be higher in diabetes insipidus. Urine output will be high in diabetes insipidus. Urine osmolarity will be high in SIADH patient. Urine sodium will be more in SIADH, and free water clearance that we discussed previously is going to be more in the patient who is excreting more free water, and this is the diabetes insipidus patient who is secreting more water, while the SIADH patient is retaining more water, so is having a negative free water clearance. That's all about the disorders of urine concentrating ability.